I guess, and it is 4 o'clock by the church bell and my phone. So good evening, everyone, or afternoon. It's not quite evening. And thank you for, of course, participating in the commission to study mental and behavioral health in Maryland. And to take part in this is our final meeting of 2020, and we'll be getting together to talk about, or we are together to talk about the year-end report that we'll be submitting to the governor. Everyone should have received at least the recommendations that have come out of the work groups and those drafts, most of which will be included in the report, but we'll be discussing them in this meeting. And I do want to thank everyone really for all the work that they've been doing and putting forth in the commission, as well as the subgroups and those volunteers, those individuals who volunteered to participate in the subcommittee groups. And so I know it's been a lot of work in a challenging year. It goes without saying that 2020 has been very challenging. And as I've said several times, borrowing from the commercial about Las Vegas, what happened in 2020 will stay in 2020. We're moving on. So, you know, and again, with all that has taken place in this year, the importance of what we're doing could not have been really stressed more so, you know, the challenges that individuals who in many cases or in some cases were not necessarily suffering challenges with their mental health, you know, are finding it difficult to get through this troubling time. So, like I said, we'll be discussing the recommendations, and in the next several days, we'll be putting together the final versions of the report and with the goal of completing it and getting it to the governor before the year-end and Christmas holidays. So before I get started, I do want to mention that for our first meeting of 2021, see, we're moving on. We're moving beyond 2020. The first meeting of 2020, which will be January 19th, we're pleased to have with us Norm Ornstein. He's a political scientist and a resident scholar at the American Enterprise Institute. He's going to join us. And he's going to be speaking on behalf of the Matthew Harris Ornstein Memorial Foundation, which he and his wife established in 2015 after the loss of their son. If you want to look up Mr. Ornstein and his foundation, you can go to mornstein.org. That's, and I'll spell it MORNSTEIN. That's ornstein.org. So at this time, as we'll move forward with our usual agenda, and what we'll do first is introductions of the commission members. And what I'll do to avoid any confusion, I'll do a roll call, and when I call your name, or at least a name that sounds like yours, if you could take a moment and just introduce yourself and whatever else you want to say just in a few seconds. So at the top of my list, I have Senator Eckert.
Thank you very much, and good afternoon, Senator Addie Eckert. I'm glad to be a part of this very important commission. And thank you, Lieutenant Governor, for your leadership in it. I look forward to continue the work. Thank you.
Senator Hester.
Hello, everybody. Senator Hester. Thank you, Lieutenant Governor, for your leadership. I'm also very pleased to be part of this commission. I represent Ellicott City and Western Howard County and Southern Carroll County, and honored to be here. Thank you.
Thank you. Delegate Kelly.
Hi, thank you. I'm Delegate Ariana Kelly. I represent Montgomery County, the western side. Really appreciative of the work of this commission, and thank you for including me.
Oh, thank you. Delegate Lewis Young. This delegate, maybe. Maybe she's not on. I just noticed that the two senators, their first name is A and K, and the two delegates' first names are A and K. I don't know how that was done. I guess the leadership of the House has decided that's what they wanted to do. They wanted to be consistent. Okay, Richard Abbott. It's Richard.
There you go.
I thought you were there.
Richard Abbott, I'm Director of Juvenile Family Services for the Maryland Judiciary, and I represent the judiciary on the commission. And it's an honor to be here. And I just want to wish everybody happy holidays before. Thanks.
Okay, thank you. I don't see Dennis Schrader on here, so unless he's, on a different screen. Dennis Schrader on?
Lieutenant Governor, I don't think Dennis is joining us today, but I'm here representing him.
Okay.
Trisha Roddy,
Yes,
Medicaid
Trisha.
Director, and serving in for, again, Dennis Schrader. So happy to be here, enjoying all the conversations that we've had over the last few months as well.
Okay, thank you. Thank you, Trisha. Okay, Dr. Jones, Aaliyah Jones.
Hi, good evening. Aaliyah Jones, Deputy Secretary of Behavioral Health Administration. Happy to be here as always. Thank you, Lieutenant Governor.
Okay, thank you. Is Major Roland Butler on?
Hey, good afternoon. It's Lieutenant Colonel Roland Butler, Maryland State Police, representing State Police Superintendent Colonel Jones. Thank you. It's an honor to be part of the commission, and I'm really proud of the work that everyone's doing to make things better overall.
All right, thank you. Dr. Boneski.
Hi, Lieutenant Governor. I'm Dr. Linda Boneski. I represent Department of Public Safety and Correctional Services, and I'm co-chair with Senator Hester. And I would like to thank you for your leadership these past couple of months with our subcommittee and in joining us. So thank you so much.
Thank you. Tiffany Rexroad. Probably got that wrong.
Good evening. I'm Tiffany Rexroad, representing the Maryland Department of Human Services, and I'm currently serving them as the Acting Assistant Deputy Secretary for Programs.
Okay, thank you. Commissioner Bahrain.
Hi, good afternoon. I'm Kathleen Bahrain. I'm the Maryland Insurance Commissioner and very happy to be with you all today.
Thank you. Director Hsu. Saw him earlier.
Steve Hsu, Executive Director of the Opioid Operational Command Center.
Okay. Christian Mealy.
Good afternoon, Lieutenant Governor. Christian Mealy, Deputy Secretary of Disabilities. However, I've joined Steve Hsu and Dennis on the MAC, and so I just got sort of tapped to be the staffing chief along with Marcia Deppen from MEMA. So I'm really glad that Tiffany Rexroad is a competent co-chair for youth and families, because I will be certainly leaning on her as we try to staff out the operation as the vaccine distribution nears. So, but good to be with you all today.
Yeah, thank you. And I was going to mention that, you have a little bit more on your plate now that you're being marshaled over to the vaccine program. So thank you. Thank you for your service, and thank you for volunteering, even if you didn't volunteer.
I did. I didn't know it was going to be for this particular role, but Dennis, he had to borrow me. So Carol said he could have me till June.
All right. Well, thank you. Mary Gable is.
Good afternoon.
Oh.
Yes. Hello, Lieutenant Governor.
Hello.
It's always when you're trying to do it fast, it's looking for that mute button.
Yep.
Good afternoon, everyone. I'm Mary Gable. I'm with the Maryland State Department of Education, and mental health, of course, is an extremely important issue in terms of all the students in Maryland public schools. Thank you.
Okay. Thank you very much. Barbara Allen. I saw Barbara a moment ago. Barbara, I think you're on mute.
You're faster than I am.
Well, I haven't turned mine off yet. So.
Okay. So anyway, I'm Barbara Allen. Hi, everybody. Glad to see everybody. And I am a family member. That's why I joined this particular commission. I serve also as the co-chair of the Behavioral Health Advisory Council, and I chair the Howard County Opioid Crisis Community Council in my spare time.
In your spare time. Okay, thank you, Barbara. Pat Matuszewski, I believe, is not able to attend. Carrie Cho.
Yes, Lieutenant Governor. Good evening, everyone. I'm Carrie Guthrie Cho, the President and CEO of Cornerstone Montgomery, a behavioral health provider in Montgomery County. Happy to be here.
Thank you. Dr. Tribarani.
Hi, good afternoon, Lieutenant Governor. Happy holidays and happy and safe holidays to everyone. I'm a child psychiatrist and I'm an associate medical director. I work at the Kaiser Permanente in the Atlantic States. Happy to be here.
Thank you. Serena Eckwood, I believe, is not able to attend. So Kimberly Watts. Kimberly, I thought I saw you.
Hi, this is Kimber Watts. I'm an attorney with the Public Defender's Office.
Okay. Is it Kimber or Kimberly?
So technically it's Kimberly, but nobody actually calls me that. I'm Kimber.
Oh, except for me, right? Okay. All right. Well, thank you. As we move through the agenda, first I want to ask if everyone had an opportunity to read the minutes from the November 5th meeting. And if there were any edits, I hope we've sent them so far, but if you have any concerns, please voice them now. Okay, well, do we have a motion to accept the minutes?
So moved.
Accept.
Okay.
Second.
Okay. So all in favor?
Aye.
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 Any opposition? Okay. All right, thank you. Well, I'm going to turn now to the subcommittee updates and their reports. And I guess we'll start with the crisis services.
Great. Thank you, Lieutenant Governor. And we all appreciate your continued support of this commission's work, which is becoming more and more important by the day. I'd also like to thank everyone here for their efforts to address the critical issues of mental health and behavioral health here in our state. I want to fill you in on the latest activities of the Crisis Services Subcommittee. The subcommittee has examined Maryland's crisis response system continuously throughout the past year. About a year ago, the subcommittee made a recommendation that the commission create a more comprehensive crisis system in Maryland. To operationalize that recommendation, the subcommittee will participate in the Behavioral Health Administration's Maryland Crisis Model Advisory Work Group that starts in early 2021. I'm sure Dr. Jones will be telling you more about that. Participating in this group will give us an opportunity to provide input into the design of the crisis services system. Our participation will also afford us the ability to monitor implementation of the 3 crisis services: focused response, regional partnerships, catalyst grant programs run through the Health Services Cost Review Commission, including first, the Greater Baltimore Regional Integrated Crisis Response Systems, which provide services to Baltimore City, Baltimore County, Carroll County, and Howard County. Second, Totally Linking Care, which will cover Prince George's County. And third, Peninsula Regional, which will cover the Lower Eastern Shore. By monitoring these programs, we can identify challenges and opportunities for expanding the Crisis Now model that has met with success in other states and that we hope to emulate here in Maryland. We're also eager to continue our collaboration with the Maryland Medicaid Work Group that is reviewing ways to utilize outpatient mental health clinics as comprehensive crisis services centers. Additionally, the Crisis Services Subcommittee recently identified new recommendations for the use of assertive community treatment, or ACT teams, here in Maryland. ACT teams are an evidence-based model for facilitating interventions for people with severe mental illness. The teams are multidisciplinary and they meet every single day to monitor their patients' progress and to identify needs. The teams generally serve as the first line crisis evaluators, and they are available on a 24/7 basis to clients who are in crisis. ACT teams have demonstrated success in ensuring that a high level of care is delivered to vulnerable patients, and the model has proven to be cost-effective in other jurisdictions. The Crisis Services Subcommittee issued a formal recommendation that the state expand ACT teams in defined geographical areas of the state based on population. In the coming months, we'll explore the feasibility of transitioning the performance evaluation of ACT teams from the Dartmouth Assertive Community Treatment Scale audit tool to the Tool for Measurement of Assertive Community Treatment, or TMACT. The TMACT tool is used to assess how well an ACT team is implementing critical elements, including crisis services. I hope I'm not driving the Lieutenant Governor crazy with my report. He doesn't care for all these acronyms, but they proliferate in this field. Teams that achieve the highest fidelity score may be eligible for higher rates of reimbursement. The subcommittee also plans to explore forensic assertive community treatment teams, otherwise known as FACT teams. FACT teams can provide people with severe mental illness with a range of services. And just as with ACT teams, one of the primary goals of the FACT teams is to increase the odds of success for these vulnerable citizens by keeping them out of hospitals and out of the criminal justice system. Our next Crisis Services Subcommittee meeting will be held on January 6th at 10 a.m. More detail and login information are available on the Lieutenant Governor's website under the Mental Health Commission tab. All are welcome. Thank you again for your support, and please don't forget that you can always reach the OOCC at help.oocc@maryland.gov. Back to you, Lieutenant Governor.
I had muted myself and then unmuted and then muted myself again. Are there any questions? This is a time to ask questions about the specific areas and recommendations that would go in. Are there any questions or concerns with regard to what Director Hsu just described or what you've read?
I have a question because Steve, you went too fast for my handwriting. What was it? Tell me again about FACT. What does it stand for?
ACT? ACT?
Yes, that's a brand new acronym that stands for Forensic Assertive Community Teams, otherwise known as FACT teams. So they're designed just very much like ACT teams with potentially more applicability to a broader range of communities. So far, ACT teams in Maryland have tended to be concentrated in larger jurisdictions with more resources. And I think we want to see a more universal application of the concept, and this may be a path toward that. But Dr. Jones or Tricia Roddy may have other comments to add on that.
Yeah, so persons who are usually involved in the FACTS team are those who are involved in the criminal justice system, typically persons who are coming out of jails or the state psychiatric hospitals that have parole probation needs and requirements for conditions for treatment in the community. That's typically who's a part of a FACT team. That's generally not for anyone who does not have active criminal charges, and those charges are mandating that they have a certain measure of treatment requirements in order to remain in a community environment.
Thank you.
I guess when Senator Hester comes up, because I know she's going to talk about the SIM model, and then, with mentioning the FACT, and that was a very good question, Barbara, that these are, it's directed to people coming out of the criminal justice system. I know we've talked about AOT or something for individuals coming out of the criminal justice system, since so many of those, unfortunately, individuals who are there have mental health, conditions, in several cases, severe mental health conditions. And so there needs to be a transition so we can talk about, you know, the interplay of this and, you know, where the commonalities are. Because, you know, one of the challenges that all of you are probably familiar with, particularly those of you who work in government or have been around government, it gets very easy to silo programs. And so that, you know, some of us have talked about, you know, AOT, and then you have the FACT program, and then you have the intervention, you know, the SIM. SIM, you know, sounds to me that it's an early intervention and intervening at different steps, but that seems to be, or seems similar with the ACT, assertive community treatment model is similar to that. AOT is more bringing in a court order, and the FACT model, or forensic assertive community, is addressing those who've come through the criminal justice system. So we can talk further about it. I just probably would need some clarification as we, you know, put together our recommendations, you know, to the governor and talk about potential, you know, legislative efforts or budgetary efforts. So I don't know if anyone wants to comment on my confusion there.
So what my thoughts when you made your comment are that there's a number of things that I'm thinking. Namely, though, the idea being that the goal is obviously to have people to have the lowest level of services that it is that they need to be maintained in a community setting, and also that they have that there is some volition or autonomy on the behalf of the person who's receiving the services to participate in services. The assertive community, so these different types of services that have been mentioned on this call, these are only 3 types of services that are for our most severely and most severely impaired behavioral health persons. Even those who have criminal justice records or involvement, or lots of people who are going in and out of jail, don't necessarily have severe and persistent mental illness, though they may have chronic mental illness, and they do need intervention and do need services. It would not necessarily be the best financial investment to enroll them in such high cost services if you can stabilize them and connect them to the needed services that are lower on the in terms of the intensity and acuity of the intensity of the services that are provided. So that's, you know, so but what you've heard about, you know, the ACT, the FACT, FACT, AOT, you're really talking about a very small subset of the behavioral health population, the most severe and sick. And then there's even still very many people who are chronically psychiatrically mentally ill, but don't require those types of services in order to maintain stably in a community environment. So it's kind of complicated. So I understand why it's confusing.
Well, you know, I mean, one of the reasons that I was and am so interested in this area is it relates to those who have severe mental illness. Yes, I am concerned about those who don't have, you know, the severe mental illness, but that was the, you know, the driving, you know, the incentive for me to really delve into this, because I just felt and feel that we as a country do not do a good job in terms of addressing those individuals that have severe mental illness. And I've said it many, many times, the woman who was tossed onto the street from the university hospital on the coldest day of the year a couple of years ago. I mean, she clearly could not take care of herself. She had severe mental illness, and it just was terrible how she was handled. We've heard from family members of those, you know, who have schizophrenia. There are articles, I referenced the one from the Washington Post a little while ago, that, you know, that have children, adult children with schizophrenia or bipolar. And we know, and Dr. Beneski can, you know, talk about it further, that we have some of those individuals in our jails and prisons. So we need something that can be addressed there. And we have these incidents where police are called to address an issue when a person is having one of these crises. And anytime you have law enforcement, it's going to escalate. It doesn't have to, but the person, if they're in a crisis, they see this person and they, see a threat in many cases. So we need to, think in terms of how we can avoid these situations as well as address the others. And, the act may be, where someone is, could be severe mental illness or maybe not as much so, but they're in crisis and the ACT team can help. But we need to think about this. Senator Nurse.
Senator Eckert, thank you very much. Does the FACT program include housing, and do the ACT, I'm familiar with this sort of treatment, the community assertive treatment, but does that include housing? Because I think safe communities and safe housing is a big piece of this. So I know it's labor intensive, having worked for a long time with folks both in and out of the hospital who are probably multiple diagnoses folks who do want to be in the community, but many times they're the very folks who wind up in our shelters, and nobody wants to touch them, if you will, because they're not always able to manage themselves well. So I'm just curious, is housing a part of that FACT team, or is that a separate issue that will have to be rolled into this delivery of service?
It's a separate issue. However, most people who are on, FACT teams and ACT teams do help people with housing issues. And so they help them to move from homelessness to housed, but the programs themselves don't have a housing component.
So it would be something that maybe our PRPs could branch out into?
Not necessarily. There's a lot of residential recovery programs that have people in them that are on ACT teams or no, RRPs generally not. No.
I'm looking at the FACT.
What's the RPR? What did you just say?
Psychosocial rehab programs. They're the programs that on the shore, there are 3, and there have been a number around the state. They've expanded now, but they were originally, when we first did the community reentry, many of our state psych patients went into like Channel Marker, Go Getter, Crossroads, to be able to have services in the community and to be able to transition back into the community.
Okay.
But I think they've changed over time to include a lot of addiction services as well. Is that accurate, Dr. Jones?
Complicated. So someone who is on an ACT team is not going to be participating in a PRP program because it would be a duplication of services. Someone who is who's on a FACT team, forensic assertive community treatment, they could be involved in a PRP in our PRP program, because the FACT team is predominantly around resources and supports. I think there's enough separation there from a day-to-day psychiatric rehabilitation, psychosocial rehabilitation that occurs in a PRP that the FACT team is not going to do. So there can be involvement between someone on FACT with PRP services. Yes. Does that answer your question?
Yes. Thank you. Yeah. Thank you.
Okay. All right. I probably would like to give more information on the distinctions, even as complicated as it is, in the approaches, and we can come back to that. Okay. Youth and family.
Good evening, Lieutenant Governor and members of the Commission. It's my pleasure to present on behalf of the Youth and Family Subcommittee. Our last meeting was held on November 9th, and we were privileged to have a presentation from the Maryland State Department of Education, which focused on social emotional learning, youth mental health first aid, health education curriculum, and the array for mental health services in Maryland schools. We currently have 3 work groups within our subcommittee. The substance use disorder group discussed the system of care for youth and adolescents with serious substance use disorders, including the closure of intensive outpatient programs and the lack of programs within Maryland. The group would like to recommend the commission hear more about what is going on with respect to the system of care for youth and adolescents who require substance use disorder treatment and how we can ensure that there are clinical services available to complete the continuum. The licensure and reciprocity work group determined that it would be challenging to find one action to cover all of the licensure boards, and broad legislative language would be required. We believe there are 12 independent boards, each with their own COMAR regulations, and additionally, the process for creating a compact can be very lengthy. Our third work group led a discussion on grading of the states regarding the danger standard for emergency evaluation and involuntary hospital admissions. Discussion focused on Maryland's rating and proposed that Maryland amend the dangerousness criteria to include grave disability. Language suggestions from other states as well as testimonials were provided. There was another viewpoint presented which suggested that Maryland does have a process for involuntary commitment and there is a need for increased training and understanding. We discussed the possibility of conducting a survey to gauge the understanding of the statute, but ultimately this seemed to be the start of a lively and valuable discussion. We submitted 2 recommendations for 2020, and that concludes the report of our subcommittee.
Okay. Yeah, I noticed that you did say you were going to be talking about the language and policy in the, at least in the last meeting associated with involuntary commitment and better defining threat to self or others. And so I do think that we need to include something in the final report with regard to working on definitions that better clarify what that means, because I mean, my limited experience, very limited experience, and then what we've heard from family members is that often it's considered an imminent threat. And that can be, you know, very challenging because the person is just not able to care for themselves. And that's something, and maybe it gets to be somewhat subjective, but I think we need to put some parameters around that definition, and we'll be willing to talk to, you know, some more of the policy people and experts in this area, but I'm a little concerned that we are still allowing that to hang out there. So I don't know.
Lieutenant Governor, if this is Christian, if I could just add, so we are awaiting sort of a white paper from the Mental Health Association of Maryland and Dan Martin. We've asked him to weigh in because there was sort of a sharp disagreement between the advocates and the Mental Health Association. And of course, this has gone to the legislature in years past, and both chambers weren't able to come up with sort of a consensus bill. So we did ask Heather to post the findings of the subcommittee's work group on the commission's website, and I am in receipt of the letter from Marilyn Martin, who is provided public testimony.
Yeah.
She's a parent from Calvert County, so I think the commission hopefully saw that as well. So as soon as we hear back from Dan, I think we do want to make sure that we're putting out an official statement. We just wanted to make sure that we were hearing both perspectives, because I know that Mental Health Association had some real heartburn about going forward with specific changes.
Yeah, I just feel that, you know, and I would like to hear them, you know, talk about what their concerns are, and are they listening to parents that are, you know, having this particular challenge. And like you said, Marilyn Martin, I know folks from the Schizophrenia Association, others have, voiced this particular concern. And, I'm not sure that they're listening to the parents and in terms of their viewpoint. So, yeah, it'll be interesting to see this white paper.
I also interject that the Behavioral Health Administration is looking at this. Right now, I wish I could give you an update upon where we are with looking at the current definitions of dangerousness and what the criteria or lack of criteria around involuntary hospitalizations. But that is something that we are actively looking into, because I also think that there's opportunity for us to provide more guidance to the field, and not myself alone, but we also believe that there's also an opportunity to provide more guidance to those who are trying to seek help for community members and loved ones as well.
Right. Yeah. The status quo is not working. So, and the training aspect, I don't know who they're talking about training judges. Judges aren't going to take training. So I'm not sure who they're talking about, but okay, we'll come back to that. And the reciprocity side of it, one of the things that, I think we can do at the state level is, of course, we'd like to see reciprocity associated with counselors and therapists. But also, one of the things that has taken place because of the state of emergency with regard to telehealth, we're now allowing outside practitioners to be able to treat patients here through telehealth. I don't see a reason that we would not allow outside practitioners through telehealth to continue that, so long as they meet certain requirements, and we could have our state board have authority over those individuals. We've seen that in some other states have taken that approach where the local board, being the state, physicians board or whoever the appropriate board would be, has authority over the out-of-state practitioner who is providing telehealth. And I think that's particularly in areas that might be less populated, where you don't have as many practitioners. The practitioners typically go to the populated areas, the urban areas. So if you're in Western Maryland or parts of the shore, or even Southern Maryland, it may be that you can find someone in a neighboring state that can provide those services. So I know, and I've talked to our legislative folks, that we want to take a closer look at expanding telehealth services to be able to allow outside practitioners, once the state of emergency is over, to be able to continue to provide services for folks. Any concerns with what I just said? Is there a doctor in the house?
I'm not a doctor, but I am a lawyer, and I wholeheartedly agree with you. Especially for our more rural areas, I would love to see more psychologists and psychiatrists from neighboring states be able to treat our rural patients, particularly for them to find a psychiatrist in Newark, Delaware, than it is in Cecil County. And so given the shortage of psychiatrists, I think that would be a very big benefit to our citizens.
Okay. Thank you, Kimber. I won't call you Kimberly, but yes, I agree with that. I think particularly in those areas where there may be less professionals available, that this type of service, could be provided. So that is something that, like I said, we've spoken to our folks that, work on legislative matters, and we can talk further with those, legislators who are part of this commission, their feelings on that as well, because it just, we have right now some unnecessary barriers to entry into the marketplace, and it's something that's been there for ages, and we can address it in a way that still keeps our people safe, and gives the authority of the folks in this state, those licensing boards, authority to oversee and have authority over those individuals, as well as if there's a private right of action, you can, provide personal jurisdiction would be in Maryland if there's some right of action. So I think it can be done, and that's something that I would want to push forward with. Also, the current telehealth bill that went through last year at the end of session, it did not include solely telephonic. It had to be video and audio. And that can be problematic if you're in areas that you don't have the broadband, or a person is not as technologically savvy. And so that's something that we'd like the legislature to take a look at in terms of expanding it to allow for, I know a lot of the doctors don't care for, providing health without seeing the person. But, in some cases, when we're talking about particularly mental health, maybe some leeway can be provided when it comes to those areas. So it's something that, we can talk further about.
Can I just chime in for a second?
Yes, ma'am, please do.
Yes, and particularly on the audio only, this is something we're discussing a lot. I just came off of a presentation that Hopkins put together for the legislature to reinforce for us how, for many things about telehealth, but particularly reinforce the audio only has been very essential for particularly certain populations who don't have access. And there are huge health disparities to consider as we move forward. So obviously, we're going to be seeing legislation on.
You froze for a minute?
Well, so it's definitely things that we're going to be looking at and hoping to move forward on.
Okay, great. That's wonderful to hear.
So Lieutenant Governor, I'll just this is Trisha Roddy. I just want to just emphasize one point with the audio only, that the reason why Medicaid can cover audio only right now with regards to the federal rules is because the Office of Civil Rights is not enforcing the privacy standards around audio only. And they've agreed to not enforce it at least through December of 2021. But it remains to be seen if they'll extend it beyond that date. And so, so particularly if you're looking for Medicaid to cover those, that could be a challenge going forward.
The privacy right, what is the privacy concern with audio that anybody can hear?
Yeah, in terms of their standard, they state that audio only is not HIPAA compliant technology. And so at the federal level right now, the Office of Civil Rights is not enforcing the privacy standards. Again, CMS has said we can cover it, but only as long as the Office of Civil Rights does not enforce the privacy standards.
And just to echo that applies not just to Medicaid, but to private insurers as well. And it's audio, but it's also other video, certain video platforms like Facebook, or FaceTime, various platforms that aren't considered sufficiently secure. So normally they don't meet HIPAA standards and they could not be used. But there has been a suspension of enforcement. There are discussions happening. I was on an NAIC, National Association of Insurance Commissioners call just this week where they talked about the fact that they do expect to continue that non-enforcement position for a longer period of time. And there are discussions about how do we fix this on a more permanent basis that are occurring. But and private insurers are in the exact same situation. If the enforcement position changes, then they're not going to be able to, basically pay for those calls because they won't, or audio, both audio and visual, because they won't be HIPAA compliant.
And their argument is that these connections are not secure enough for that purpose.
There are some that are video-wise. There are some that are secure.
Yes, some that are and some that are not. Yeah.
So if you make sure you get one of the secure ones for the video. Audio is still an issue though.
Yeah, I still think that's ridiculous though, but that's another story. Yeah, so they think somebody's tapping the phone and is gonna listen in on their personal, private healthcare information. If anything, they're gonna tap the phone to see if you're a Chinese or Russian spy, but maybe not just to get your, that information or okay. What it comes down to is we need Delegate Kelly down there in Congress to make a move, because that's what's happening. Congress doesn't want to touch it. They're just, they could correct this whole thing if they, got around to it. So, that's a problem. We're still going to go forward with it. We'll see what, and we'll yell at the delegation with the support of Delegate Kelly, right?
I will say also that there are, on the payer side, since we heard from the payers, that I have also been hearing concerns about quality of care and overutilization, but I am often hearing those concerns expressed for sort of with an exception for behavioral health, that there's a recognition generally on the payer side that behavioral health has different telehealth needs. So that's the space we're working in.
Yeah, and I would think the experience of 2020 that people would feel that, on the behavioral health, you need to reach these people where they are, and it doesn't always mean that you need to see them or, be in the same room with them. I mean, would be wonderful, but you need to reach people where they are, and that's a challenge. So, okay.
That's been one, Lieutenant Governor, that's been a good thing, because many of those folks who need to be separate from everybody else because they can reduce their anxiety that way do much better with those kind of phone contacts. Yes.
Right. Okay. All right. Well, thank you. I kind of lost my place now. Any other questions on youth and family? Okay. Finance and funding.
Evening. So I can be real quick. As you know, our recommendations for going forward focus on continuing to improve the behavioral health system of care within Medicaid, meaning across our administrative service organization, and then integrating with our managed care organizations who are responsible for our somatic care of Medicaid enrollees. And we're continuing that work through a work group. We met this past month, and we had a really great presentation from the Community Behavioral Health Association, where they presented a potential model for our managed care organizations to consider, where essentially they have put together a high-performing network of behavioral health providers in which they would contract with our MCOs to better coordinate care and share data. So it was a very interesting model for our MCOs to consider, and gave a lot of food for thought. We have asked the work group to come up with some recommendations on potential projects that they would feel would be most meaningful to work on during the next 6 months. We know everyone is very, very consumed with the COVID-19 pandemic, as well as with the legislative session. And so we wanted to make sure we were prioritizing our projects. And so we're looking forward to their feedback. And then lastly, with regards to the Finance Subcommittee, we did have a meeting on November 4th, and we gave an update on the grant that we've received again through the Opioid Operational Command Center. And again, that grant is really focusing on developing a model, looking at Medicaid's role in expanding and improving the crisis service network. So one of the key things that Medicaid is considering is what new services could it cover under Medicaid. And then, you know, when we look to add a new service, we look at requirements that can be covered across the state. So we look at standardizing those provider requirements, et cetera. So lots of good discussion, and I will pause and turn it over to Commissioner Borrane and see if she has additional updates that she would like to provide.
Just a few things on the private insurance side. To update from our report last month, we did actually have the first public meeting on the mental health parity regulations that the administration will be developing and adopting. That meeting took place on November 23rd. It was a great meeting. We heard from Milliman, we heard from the Path Forward, we heard from the Bowman Family Foundation, and many, many both consumers of mental health services and also advocates and other stakeholders. So it was an extremely, I think, instructive and productive meeting. It's the first of several. We're looking to schedule the next one probably between the end of January and the beginning of February. And while this isn't exactly related, I guess, to our work here on this committee, I will say that coming out of that experience, the MIA will be hosting a question and answer. We're looking at a 90-minute question and answer period. We'll send invitations to everybody, and also solicit questions to receive answers. But we're looking at January 12th as an opportunity to answer questions for both policyholder, consumers, and providers who are finding it challenging to work their way through the insurance claims process. So we want to help people understand what they have to do to get out of network coverage, et cetera. So I think that'll be a very productive thing. We also, as you know, we had promulgated our updated regulations for network adequacy. The comment period on that ended December 4th. We're currently reviewing those comments. We have scheduled a public hearing for December 18th, where we'll really are going to, you know, apropos of the discussion we just had, talk about telehealth and how telehealth factors in and when it appropriately factors in to network adequacy. You know, it's a double-edged sword. It is absolutely correct that telehealth has been a godsend to people and has given people, it reduces barriers. It's a critical tool. But we also have to be really careful that that we're sure that people can access telehealth, and how do we allow it to count toward the adequacy of an insurer's network, because it is not the be all and end all, and it's not a complete substitute for an adequate network. So that's something that we'll be talking about in great detail, and we will want to hear comments on that point. And with regard to, I guess, overall, I don't know if we're talking about our recommendations at this point, but the one other thing that we've sort of suggested that we begin to bring to the table, you know, Tricia obviously, you know, deals with Medicaid payor. We deal with private insurers as payor, but a really big piece of this picture is the self-funded, you know, community that I don't regulate and, you know, the state doesn't regulate. And so how do we bring them to the table? How do we begin to talk about alignment and consistency across, you know, payer groups generally, but bringing them in? And, you know, in the context of looking at mental health parity and spending time with folks at the Path Forward, what we've been very impressed with is their success in bringing together employer groups as purchasers and consumers of mental health services through the plans that they develop that are administered by third-party administrators, many of whom are large insurers, many of whom are, you know, providing their network to those employer groups. There's a tremendous push among employers to have better access, more adequate networks. And so we think bringing them into this discussion as we, you know, try to create uniformity among payers, it will be an important part of making sure that financing exists for mental health services. So they're the third piece of the puzzle that we think we should add into our discussions in this subcommittee as we go forward.
Okay. Very good. Any questions? The finance and funding group? I saw Delegate Young, you weren't on originally when we were doing our introductions, but I saw you put in a note saying that you had bills in the 2021 session. What bills were you talking about addressing?
I wrote that comment while you were talking about telehealth and that you were hoping that the legislative body would extend some of the attributes of telehealth that are working, in particular, the audio only.
Okay.
That was my reference.
Oh, okay. Well, thank you. Glad that that's happening. So.
Oh, and in fact, I pre-filed it.
Oh, okay. Well, I don't know. You might be, Delegate Kelly, she may be moving ahead of you on the.
Oh, no, I didn't have the bill. I was meant.
No, I'm just not. No, I'm not saying about the bill.
Delegate Kenya Melnick has a bill. They're leading on these issues. I'm just
very good. Very good. Okay. Thank you. Okay. I guess it's the Public Safety Justice.
Thank you, Lieutenant Governor. I'd like to provide just a quick update on the state summit, which so many of you helped and participated with, and then provide an overview of our recommendations. And I'll look to my co-chair, Dr. Vineski, to chime in where I forget something, because I probably will. But can I just, let's see. So the State SIM Summit was held on November 17th and 18th, and we have had over 300 attendees listen to great presentations of what we are doing really well in Maryland across each of the 6 intercepts. And I would be remiss not to thank you, Lieutenant Governor, for joining us on day 1, and Steve Hsu and his team for helping us pull this amazing feat together in just probably 4 or 5 weeks. On the second day of the summit, we had approximately 100 stakeholders who met in smaller work groups. And in each of these work groups, they were split up along the summit, the intercept, sorry. So we had group 1 focus on intercepts 0 and 1, and the next group focus on intercepts 2 and 3, and the final group focus on intercepts 4 and 5. And what they did there was to identify gaps and opportunities for improvement in the state of Maryland, and then to kind of rank order them with a quick vote in terms of their priorities. Now, our the consultants that we received with the technical assistance from SAMHSA, their group is called PRA, Public Research Associates, and they are currently working on a final report which will articulate the recommendations for the state of Maryland based on the output of those working groups and the best practices from day 1. And I just wanted to share with you some of the highlights that we heard during the summit. It was interesting. There was kind of consistency across some of the 3 groups. So all 3 of the work groups highlighted the need for consistent housing support to fulfill the needs of individuals prior to interaction with the judicial system. That was really interesting. All 3 groups also highlighted the need for integration and centralization of key services. Although it was slightly different in different intercepts. For example, 0-1 encouraged the replication, expansion, and interconnectedness of the crisis intervention services, which I know that our crisis subcommittee is working on. The Intercept 2-3 work group highlighted the need for increased pretrial planning and linkages there. And then the Intercept 4-5 group mentioned the need for one-stop shop centralized resources to make sure people are getting connected to the services they need. I heard a horrible statistic, which was that when somebody's released, they have more appointments they have to make in the first month than there are days in the month. So imagine just being released from prison and having to go to 33, 34 different appointments. So there were other recommendations that were very specific to the individual intercepts. One of the highlights from 0-1 was encouraging the development of prevention and intervention resources, such as the use of ACE surveys, community and inpatient treatment resource models for children and youth, and the expansion of trauma-informed care models. Something from Intercept 2-3, articulation of the need to increase pretrial services, screening, and planning. And from Intercepts 4 and 5, the need for interagency collaboration and increased opportunities with employers upon reentry. So that's just a quick overview. I suspect the report from PRA will probably be about 20 pages, and we'll articulate these in greater detail. But that's just to give you guys a flavor of what was discussed. Let's see. So in doing the recommendations then for this year's report, you know, it really took two subcommittees, you know, a lot of time to pull together this state summit. And we really want to make sure that the outcomes are in fact, you know, implemented, resources permitting, over the next few years. And so therefore, our recommendations have to do with the implementation of this and the need for cross-agency, you know, planning, such as this commission provides. So the 4 recommendations that were circulated, the first is to, you know, formalize a body to address the needs of justice-involved persons who interact with behavioral health disorders. And obviously, this dovetails with the charge of our subcommittee, but given the broad range of recommendations we anticipate seeing, we kind of need some staff or something like that in order to really track and make progress. So the second recommendation is to develop a mental health criminal justice center or center of excellence. In other states, they've utilized university resources to track programs and to centralize these resources and provide technical assistance, you know, as needed. The third issue is really to identify a mix of funding strategies. And, you know, this year in particular, we're working in a resource constrained environment, but we heard time and time again that in order that in some of these areas, we really know what to do. It's just a matter of meeting the funding and resource constraints in order to get them done. And we do believe that by looking at strategies that leverage state, local, federal, private sector, and nonprofit dollars, we can work together to really put into place some of these technical recommendations. And the fourth recommendation has to do with broadening and formalizing the county level criminal justice / behavioral health planning committees with that of the state. So we're seeing lots of great activities across the counties. Several counties are involved in stepping up initiatives, or they may have police crisis intervention teams or advisory boards or treatment court advisory boards. But this, we think that strengthening the cross-county collaboration will really help to accelerate all counties to share their best practices. And in that end, the second part of our technical assistance grant from SAMHSA includes a train the trainer course for SIM mapping at the local level. And so if any of you personally or any of you know others who might be interested in becoming a trainer, Marianne Gibson from Steve Shue's office is helping us to coordinate this next, you know, training, which we anticipate happening in the first half of 2021. So let me just open it up. And I don't know if Dr. Beneski or any of the other great members of my committee would like to add anything, or Steve Shue.
I would just say the event was a great success, and it was a pleasure working with you and your team, and special thanks to Nithin.
Thank you. I'll pass that along. Nithin is my chief of staff. Okay. Well, seeing no immediate ads there, I just want to mention that our next subcommittee will be on Monday, January 11th at 2 p.m. And of course, I'm also happy to answer questions. Back to you, Lieutenant Governor. Thank you so much.
Well, thank you. And yeah, I guess, you know, in the previous, I guess, in the crisis subcommittee discussion, when they were talking about the, to go back to my notes, fact, forensic, ACT, that, you know, again, there's that overlap, at least I think it's there. Dr. Jones told me I'm being too simplistic. You didn't, my words, not yours. But it seems as though there's, you know, some overlap in terms of how to, you know, approach, you know, putting together a planning body or to address those who are involved with the criminal justice system and coming out still with ailments. And I know we had talked about that in the context of assisted outpatient treatment, but it sounds like FACT is, might be the avenue. And I have to kind of explore that a little bit more. And Dr. Boneski, you can help me with that.
I was going to speak earlier. The persistent mentally ill, we have a significant portion in our prisons. So as far as the definition or the narrowness of the criteria for those teams would be something to look at, because we have many people that end up going back out. We try to get services and they come right back. And that goes for the conditional release people from the state hospitals. They're out on conditional release and maybe go off, not do their thing, commit another crime, and they end up back with us. So there's a lot of interaction with the forensic and, the seriously persistent mentally ill, I can see from the statewide perspective.
Yeah.
Can I just add a comment, Lieutenant Governor?
Yes.
My understanding is that functionally a FACT team and an ACT team do the same basic things for people who have similar clinical circumstances. But there's a couple issues at play. One is, we know that historically, at least in Maryland, ACT teams have not been applicable to smaller jurisdictions with more limited resources. So one of our goals, at least from the OCC's perspective, I don't know if BHA shares this, so I'm just speaking for the OCC. We want to see a full rollout across the state of these types of strategies. But these smaller jurisdictions, these smaller rural jurisdictions, just don't have the resources to drain the whole ocean. And because this particular population, people who are caught up in the criminal justice system, have very disproportionate behavioral health issues, that's a natural way for a rural jurisdiction to get the most bang for its buck, to concentrate its efforts on this population with a more narrowly focused FACT approach than by trying to cover the full breadth of potential patients through a traditional ACT team, which really hasn't worked too well.
I think Dr. Jones was going to, say that they're not quite the same thing, but go ahead, Dr. Jones.
They're definitely not the same thing. An ACT team is like a care team for an individual in a box. Every single thing that you need for care for that individual is in that one particular box. They have the psychiatrist, they have the nurse, the drug counselor, the peer recovery specialist, the person who's doing any other sort of psychosocial therapy, working with the family. Everything is contained within one system. FACT is more of coordinated care. So the person is receiving, it's more like heightened case management. It's not the same thing as an ACT team, two completely different things.
So,
and I think that the point that I'm trying to make is that the system has lots of opportunities and lots of ways that it could improve to ensure better care for people across the board. And that what I want to be careful about is to not get locked into one or two or three methods of treatment when there's a whole host of things that one could do to help improve outcomes and help to prevent decompensation for patients. I think that and that's all that I'm trying to communicate.
Yeah,
yes, it is. Yeah.
I mean, I can appreciate that, and one size doesn't fit all. And so that's why I mentioned early on that, what drove me to to this particular issue is the severely mentally ill, those who have severe cases. And I don't want to diminish those who, have not easily, but whatever, they're it's not as severe. It is something that can be controlled there, easily, and there's, help for them. But I'm talking about, that's what has driven me. And so, maybe what is, best to do is to, take portions of it, like as we're in talking to Dr. Boneski, in terms of those who are coming out of the criminal justice system who have severe mental illness. And if there isn't a warm handoff to something, they're going to come right back, possibly have done either the same thing or something worse than what they did before, or they become a victim, when they come out. And the same for other individuals who may not necessarily go through the criminal justice system, but are constantly in the emergency room, or they're a challenge for their family. And so some areas like definition of what it means to be, a danger to themselves or others can help, as well as maybe, one start is looking at the those coming out of the criminal justice system through the SIM model, but maybe also the FACT model, and what can be done there, and of course, how we can fund it. And, just making sure people have a place to go when they come out. And hopefully not returned, so. Any other comments? I think one of the things I'm going to do, and maybe it's working with you, Dr. Jones, and some others, is and maybe it's because, like Kimber, I'm a lawyer, so I'm used to reading things. And so I may want to create a chart about these different, concepts, ACT, FACT, AOT, just so I can distinguish the different approaches to addressing some of the challenges that we're trying to deal with. So I'll probably talk to you later, and whatever chart I come up with, I will distribute it to the full commission. So any other points or questions that want to be raised? Or is there any other items that we didn't cover? Okay, I'm going to turn now to the folks who have asked to speak to us. I'm going to start with Ms. Martin. She sent a written testimony, and Ms. Martin, I'm going to, underneath my tablet here is a book that you referenced, which is Ron Powers, No One Cares About Crazy People. It is a very good book, well written, extremely well written, combination of technical and, the human aspect, along with the technical issues associated with, severe mental health, brain disease. Ms. Martin, you still have your mute on. We can't hear you. There you go.
I got it. I'm still kind of new to this.
That's all right.
I was told 2 minutes, so I've condensed whatever I could. Basically, I need to tell you that my 37-year-old son has schizophrenia, which is a severe neurological disease. Over the years, I have been unable to obtain timely treatment for him because the danger standard for emergency evaluation is not defined in statute. It is too often interpreted to mean imminent danger of bodily harm without consideration of grave disability or history. Research shows untreated psychosis results in structural brain damage and worsening outcomes, which can be prevented by expedient treatment. I'll give several examples, shortened form here. One is a judge denied my petition for an emergency evaluation for lack of immediacy, although the statute did not require imminent danger. Another one is a neighbor reported my son's threats to him to the police, and the police also failed to petition. My third example is his psychiatrist at the clinic failed to petition when told of his deteriorating behavior. The result was that my son physically attacked my 70-year-old husband. Now my son has a criminal record. I was encouraged by the report of the work group of the Youth and Family Subcommittee, whose resolution supported a new statute defining danger to include failure to meet basic survival needs, inability to protect oneself from harm, or failure to seek needed medical or psychiatric treatment to prevent physical or psychiatric deterioration due to mental illness. However, as in past years, the Mental Health Association made objections which thwarted and delayed action. They're still casting doubt on the existence of anosognosia, the disease-based lack of insight, despite recent MRI evidence and broad national acceptance by the American Psychiatric Association. They're also casting doubt that lack of treatment causes homelessness and criminalization, which ignores years of research and family testimony. And last but not all, there are more, but they've suggested training as a solution, which was tried extensively in 2002 without solving the problem. In the past, Maryland legislators have failed to act without unanimous agreement among mental health advocates. I hope this doesn't happen again. I hope the administration will listen to families like mine and will be bold enough to act on its own to promote legislation to help eliminate the barrier to care. And in my written submission, there's a link to this article on the research that I cite in the first paragraph.
Right, well, thank you.
Thank you.
As you probably heard earlier, I'm concerned about the definition. I think Dr. Jones has talked about, that the department is looking further into the definition of danger and what does it really mean, in that. And I have, experienced that too, where it's, the perception is imminent and the person may still be in a crisis and so there's a challenge associated with that. Okay, any questions for Ms. Martin? Okay, thank you. I'm going to go to Maria Eval.
Hi, good evening. Evila, it's pronounced Evila.
I'm sorry.
No problem. I give you an E for tremendous effort. You kind of stuck it out there for a second. Thank you for allowing me to participate in this meeting. I actually work very closely with Dr. Beneski. I formerly worked with DPSCS State Psychology, and now I'm the contract manager that delivers mental health services along with State Psychology and DPSCS. I'm so impressed by each member of this team. And interestingly, although serving in a forensic mental health capacity, whether it be treating patients directly or now from an operations perspective, for the last 20 years, listening to this team come together in Maryland, I can see a lot of commitment. And I would encourage, of course, having worked specifically with those who are incarcerated, that when reevaluating the criteria for our patients, I know the challenges, again, especially being now in operations from a budget perspective, and looking at avenues such as telepsych has been very helpful. But please do consider expanding that definition so we can capture as many patients as possible. In our new contract period, which started in January of 2018, we've been here in the state as a company for about 14. The new contract includes reentry specifically because we are aware as a nation that we are failing in this regard, hence the recidivism rate. And so I am new to joining. This is my first time seeing and e-meeting a lot of the players on the team, yet I feel such a sense of hopefulness by the fact that we're having these kinds of discussions. So that's really my motivation for being here. I look forward to sharing this with other members of our team, and hopefully they can participate as well. Thank you.
Thank you. Yeah, please feel free to share, that what we're trying to do here. How did you hear about this? Through the interweb?
So through Dr. Beneski, actually.
Oh, okay.
So she's my partner very closely, as of course she's the director of mental health and DPSCS.
Right.
And I'm the contract manager for Centurion, and we're both in partnership managing the mental health team across DPSCS. But she, as a side note, was actually formerly my supervisor when I worked for DPSCS State Psychology, and she comes with a wealth of knowledge, and as a leader and advocating for the severely mentally ill, there's nothing more inspiring than someone that is committed to both policy, but also the ground reality. How do these beautiful words on this paper translate into how effectively they're implemented? So.
Okay, well, thank you. Thank you very much.
Thank you.
All right. Michael Byer.
Hello, Lieutenant Governor. How are you?
I am well.
First of all, I want to take my hat off, even though I'm not wearing one, to all of you for the huge amount of work you've decided to take on. I work at a lower level out of schizophrenia, but I do worry about the opioid crisis for the wounded warriors. I do worry about Aetna's Medicare efforts, and I function at a lower level than some of these conversations. But I do want to share that there's a lot of funding already in place that I haven't heard mentioned at almost none of these meetings about the money that the federal government has to give the states to fund things like the opioid program and for things that states have to do to comply with receiving and keeping the monies that they get. So I want to roll up my sleeves and say we want to help, because there's lots of free money. Not that that's like a really concept, but it's sort of true. Out there, there's lots of Medicare money. There's less Medicaid money. And my colleague, Alan Tien, who's a Hopkins doc, we're a bunch of people out of NIMH. And we want to say that, half of this is out there to use and do. So we really appreciate being able to share that part with you. And to stay and to say if there's anything we can do, we're here for that with great admiration for the work you're doing.
Well, thank you. And I know Director Hsu, who's in charge of the executive director of the Opioid Operation Command Center, is aware and always tracking federal support for the efforts that we have had in our administration over the last 6 years, addressing the opioid issue in particular. And this commission, looks at both and the interplay or the co-occurring conditions associated with opiate dependency or drug dependency and mental health. And so, we thank you. And if there's any additional information you want to provide.
Well, as a quick one, and then I'll be quiet. Most of these opioid programs are 6 months long and people say goodbye. Our Wounded Warrior program is 12 months long. It ends up costing half the price of the typical 6-month program. And it has a success rate of twice the amount. So these are all different paths than what's typical. It's twice as long, it's half the price. And with Steve, I'd love to talk with him about it because he's a different thinker too.
Okay. All right. Well, very good. Well, thank you. I think I saw Steve gave you a thumbs up. So feel free to reach out to him. And hopefully you're talking to our Veterans Affairs Department as well. That's very concerned about this area.
If someone on your committee, if anybody wanted to send me a note, because it's hard to find who's where around here, I would gladly do that. So I appreciate any direction.
I think Steve's going to do that. He just did another thumbs up.
Michael at m3information.com. We're also LabCorp's mental health group. And the big difference when you talk about the work you do is we're experts in bipolar disorder and PTSD. So what we do is we enable measurement-based care of complex conditions rather than making just everybody depressed. And as you know, these messy conditions are what are the underlying root causes of several of the upstream problems.
Okay. All right. Well, thank you. I see Steve just sent you a message.
Thank you, Steve.
Okay, Paula Bird.
Hi. I also want to thank you all for all of the hard work that you are doing, and I'm happy to be here this evening. I am the co-founder of a psychiatric rehabilitation program, or PRP, which was mentioned briefly earlier. And so I just have my little 2-minute talk to talk about what we do. Studies and statistics show that the state of mental health in America is getting worse. But I'm not here today to dazzle you with numbers and reports. That information is available for any of us to search for as we see fit. I'm here to talk to you about the people that those numbers and reports represent. People of all ages, people that you know, a friend, family member, student, colleague, mother, father, son, daughter, maybe even you. At some point in our lives, we all experience feelings of self-doubt. We question our strength and ability to persevere. We face challenges and obstacles that we're not sure how we will overcome. For some, these thoughts or feelings last a moment, a week, a few months, but for others, they may last a lifetime. Some people push through. They press down the doubts, the fear, the pain, and keep going. And because they can, it somehow becomes a belief that everyone can push through. While I believe that everyone can overcome, that everyone has potential, I know that not all of us can reach our full potential on our own. We need help. We need as much help as we can get, especially today when there are very few people any place on earth who have not felt the anxiety produced by this worldwide pandemic. People not only need mental health professionals, but they also need professionals who are trained to help them practice skills to reduce anxiety, improve their self-care, help them find a job, help them manage the day-to-day activities that can become so overwhelming when faced with mental illnesses that leave people feeling isolated and alone. Health issues, whether they are labeled as mental or physical, are real, and they have no respect of person. Psychiatric Rehabilitation Program, or PRP services, provide that extra level of support to individuals who are seeing a therapist and need more help and empowerment to be able to manage their daily lives and unleash their full potentials. Not only do we need to ensure that current Medicaid sponsors PRP services continue, but we need to expand PRP services to include private insurance companies and Veterans Affairs so that they can be made available to people of all walks of life fighting to overcome mental health challenges. Let's find ways to grow and improve mental health support services for everyone in our community.
Well, thank you, Ms. Bird. Where's your facility?
We're located in Randallstown.
Okay. And what's the name?
Unleashing Potential, LLC.
Okay. Oh, it's right here. Okay.
Yeah.
Okay. Well, any questions for Ms. Bird?
I would just say that I agree with her. I think that PRPs are one of a number of behavioral health services that are only covered by medical assistance and uninsured, which is medical assistance, and that needs to be expanded to the entire population, including those who are covered by other payers. So thank you for being here to share that.
Thank you.
Okay, thank you.
Ditto. Senator.
Oh, go ahead, Senator Ecker.
I'm just saying ditto. I can't, we just had that discussion here on the shore that the PRPs are mostly Medicaid, and we need to figure out how we involve the two groups that the previous speaker talked about, veterans and private insurance.
Right, right.
Would make a big difference.
Yeah, Director Breen, is there a way to include the private insurance carriers or to be able to, cover their, pay for treatment in those facilities?
Well, I definitely want to follow up, and I was going to reach out to Ms. Bird and also to Senator Ecker to talk about, for me to get a deeper, more granular understanding of what the issue has been and what we can do about it. So I don't have an answer for you right now, but except to say that I actually was writing a note to myself to follow up.
Okay, thank you. Okay, Evelyn Burton. Ms. Burton, welcome back. You're still on the mute. You're still muted. It's still muted. There you go.
Finally. Okay. Hello, and thank you for carrying on this important work. I'd like to start by thanking Ms. Roddy and her team at Maryland Medicaid for their intention to include the IMD exclusion waiver for serious mental illness as part of the renewal process of Maryland's 115 demonstration waivers. This IMD exclusion waiver will help people access much needed inpatient care for mental illness and will save the state millions of dollars that it is currently paying each year to cover the costs of IMD hospitals that can and should be mitigated by federal funds. I'd also like to thank Ms. Roddy for reaching out to CMS to inquire about a faster approach to obtaining the waiver sooner, the approach used by the Medicaid program in Massachusetts. The last I heard, CMS had not responded yet to Maryland, but our members with an adult child who needs services covered by the waiver still appreciate her efforts. And I am wondering, and when I finish, if there's any update on that. However, if Maryland does not expect to receive the waiver until 2022, then I think it's critically important that state funding for IMD hospitals, which was reduced this year, be increased in the coming budget year. This will ensure that Medicaid eligible individuals will continue to have access to the special and unique treatments provided by our IMD hospitals, such as those with dual diagnosis with developmental disabilities and serious mental illness. I hope this can be a recommendation of the commission. Also, I'd just like to thank the chairs of the Youth and Family Committee for posting the slide presentation that as chair of the Danger Standard Work Group, we presented at the last meeting. And I encourage all the members of the commission to look at those slides online, and please contact me if you have any questions or would like further information. And I want to put a plug in.
Oh, you just muted yourself when you plugged.
Oh, I hit the computer by mistake. It's called, the book I wanted to recommend was called Insane Consequences, How the Mental Health Industry Fails the Mentally Ill by DJ Jaffe. It's primarily a policy book. It looks at all sorts of different levels of government and different organizations and makes a lot of great suggestions on how to improve the system as a whole.
Okay, Insane Consequences. What was the author again?
DJ Jaffe, Jaffe.
So I'll just quickly answer your question, Evelyn. Unfortunately, CMS hasn't gotten back to us. Again, I suspect that we are going to get an expedited review by CMS, particularly during this period of time where they're so busy with other COVID-19 waivers. But it is, it will be included in our 1115 waiver submission. So we'll start that process again in June with the hopes that it would be approved and effective by January 1st, 2022.
Well, thank you so much. I really, and all our families appreciate it.
Absolutely. I'm looking forward to working with you.
Thank you.
Okay. Any questions for Ms. Burton? Okay. Christina Granados? You're on mute also.
There we go. Hi. Thank you again to everybody who's here dedicating a lot of time and effort to this cause. I wanted to read my statement. I have a brother who has been sick with schizophrenia for 22 years. And Maryland's vague, undefined danger standard has been a barrier to his critically needed treatment on many occasions. The result has been his suffering He's been homeless. He's been incarcerated. He's lost relationships, and he's violently attacked 4 family members on different occasions. Millions of wasted taxpayer dollars for him to be incarcerated, and families with children, including mine, that live in fear of harm when he is ill and not able to get help. In his 20s, my brother began hearing voices and had paranoid delusions. He was completely unaware that he was sick and refused treatment. The first violent attack was on our father, who he knocked down and choked severely until my other brother removed him. He agreed to voluntary hospital admission, but he checked himself after 2 days because the inpatient doctors refused to certify him for involuntary admission. My brother threatened my husband and I, who were living with my parents at the time, and said that he slept with a butcher knife under his bed in case he needed to kill us in our sleep. The police took him to the emergency room, and the doctors refused to certify him there as well. He couldn't safely return home at that point, and he was homeless on the streets until my aunt's family took him in, even though we told her it wasn't a good idea. And my brother ended up attacking my grandfather in one case, and eventually he beat my aunt and her husband in the head with a baseball bat. He calmly called the police and stated he intended to kill them, but couldn't go through with it. Both my aunt and uncle were hospitalized and are disabled because of that incident. My brother was put into a forensic state hospital where after 5 years, he finally received medication over objection, which successfully treated his psychosis. He was released. He was put into a halfway house program. He got a job, bought a car, started to go get ready to go to college, mended relationships with us and his son and the rest of our family. This past year, unfortunately, he stopped taking his medications. He moved out of the halfway house where people were monitoring his medications and status. He started becoming having hallucinations again. He was posting things on social media with violent content, such as feeling cute, think I might go kill. He concocted a plan to live in the woods near my family. He wanted to leave his apartment and come be my neighbor. I'm homeless. And this terrified me, knowing he could show up at my door at any minute while psychotic and violent. Research does show that the strongest predictor of violence by a person with mental illness is prior violence. I asked the Anne Arundel County crisis team to petition my brother for emergency evaluation to get him needed hospital treatment before he became homeless or attacked someone. I sent them screenshots of his violent posts and thoughts of murder. I gave them his psychiatric violent history. The mobile crisis team decided he was not dangerous enough yet to meet the current danger standard, which did not allow them to take into account his past violent history or his significant psychiatric deterioration. Now my brother has been evicted and lives in his car. My family is in grave danger and lives in fear. How can I protect my family when there's no help until it's too late? And why can we continue to wait for tragic outcomes before we help these medical patients with their illness? It's absolutely shameful that since 2001, families like mine have pleaded for help from Maryland legislators and administrators to remove this barrier to care, and nothing has been done. I'm pleading with each of you to expedite your review this year, to recommend defining the danger standard in statute to include a grave disability with psychiatric deterioration and history taken into account. This will allow family, law enforcement, and medical professionals to help patients with serious mental illness to get help when treatment is needed, and not after someone has actually caused harm to oneself or others. Thank you.
Well, thank you. It's okay that, it's understandable that you'd be emotional about this. And it's a major concern to me because of individuals like you and Ms. Martin, who we heard from before, that the families are the ones that have to deal with this when they have an adult family member who is suffering. And there needs to be help, and the idea of additional training does not address that concern. That the definition needs to be improved so that, an individual who is, in crisis and doesn't realize that they're in crisis, that something can be done. Like you said, when your brother was in his 20s and he first started to show the signs, which is typical of schizophrenia, he doesn't think anything's wrong. And if you're saying that you're not acting the way you normally do, it's like, no, you're not acting the way, And so it becomes very difficult, and particularly once they're 18 and above, to really get any kind of treatment and assistance. So thank you for, your testimony. I think we all heard you. And, I'm going to be, looking to see that we do something this year with regard to this definition, defining what danger to self or others really means. So I appreciate your willingness to share with us. Senator?
Thank you very much. And thank you so much, previous speaker, for sharing. That takes a lot of courage. And I know it's very difficult to share those kind of personal experiences, but I appreciate you giving us a list of criteria that could be added. The previous history of incidents and all of that. So thank you so much. We have actually been fighting this battle for as long as I have been involved with the legislature and with healthcare delivery, working in a state hospital for over 30 years. So this is not new, and I hope we can get this done this year. Thank you, Lieutenant Governor, for championing that.
Sure, absolutely. I think we have one more person, Alan Teen.
Thank you, Lieutenant Governor. Every time I've joined these meetings, I've been amazed at how complex and daunting the work all of you do is. And every time it's more details that really are just keep evolving to make it challenging. I'm a neuropsychiatrist. I'm a public health science informatician. I'm kind of a spiritual and scientific brother with Michael Beyer, who spoke earlier. We really are working to join forces. And I think there's so much complexity that we need to think about it systematically. And I'm working on the concepts and really the details and framework of how to strengthen the suicide prevention ecosystem. And I think it's almost identical to trying to strengthen the opioid overdose prevention ecosystem. The same causal mechanisms I think we know are present underlying those kind of tragedies. And some of the complexities are in the data, the science, operations, culture, software technology, how to educate and train people, how to bridge across silos. And of course, I've heard you speak multiple times, Lieutenant Governor, about the policies and the complexities and the frustrations of policies. I do feel like the way to get policies to change and improve faster is to have more data and better data. And even I've spoken over the past year with some of your colleagues, some of the delegates from Baltimore County, and learned that there's an effort at the state level to create an office and some staff to go out and actually evaluate the performance of programs. I'm not sure if that continued because of COVID. I think that was a conversation I had in January or February. I learned a little bit about that. But that's the kind of thing that actually Michael Beyer, myself, we are here to provide tools, cloud data tools, the scientific validation, the evidence for why these measurement tools work. And I think, as Michael said, there's opportunities to just, support that with existing reimbursement models, Medicare, Medicaid, others. Certainly, if we can collect data over time, over the life course and across different silos and agencies and share that data, it's going to be easier and easier to prove why it makes sense to spend money now, because it's going to save money over the next, years and years and decades. So I just wanted to share that with you. We are getting significant progress across the state of Pennsylvania, Michigan, Kansas, and some counties in California, and largely in the education systems with prevention, early intervention, but also acute treatment and social service coordination. Would love to figure out a way to move some things forward in Maryland. And I live in Baltimore County.
All right, well, thank you. Questions for, and is it Tien? How do you pronounce your name?
Tien, thank you.
Tien, okay.
It's the middle 4 letters in the word patient.
Okay. Any questions for Dr. Tien? Okay. All right, well, I want to thank everyone for, participating and volunteering your time to this commission. It's extremely important. As you can tell, it's important to all those who testify, all the organizations, and all of you who have chosen to be involved in this. We will be putting together the draft report and getting it out to everyone for additional comments. If I do get around to putting together my chart that I mentioned before, I will send that out as well. I should always say that if I get around to doing it, but I do want to, it may not be before we get the final report out. It may be after, but I need to kind of visualize where all what these approaches are and the elements associated with them. Our next meeting will be January 19th of 2021. So we will then be, past the 2022, and we'll be on the road to recovery. We are, hopeful vaccines will be coming down the pike to help us address the coronavirus. I do encourage everyone to get a flu shot if you haven't already done that, the seasonal flu shot. The numbers I recently heard, and Dr. Jones probably knows this better than I do, from the health department is that we're not having a bad seasonal flu period, which is good. The unfortunate thing is we're having a bad coronavirus flu season. So when the vaccines are available, encourage everyone to get it when it's available for us, and as well as encourage your friends, family members to do the same. And so with that, unless there are any comments, questions, concerns, we'll close out the meeting. So thank you all, and have a wonderful holiday season and Happy New Year.
Thank you.
Happy holidays, everybody.
Thank you.
Thank you. Okay.
Good work.
Thank you. Thank you.
Thank you, Senator.
Good evening.
Good
Happy
evening.
holidays, everyone.
Thank you all.